Let's start with DBT because the risk factors for PE and DBT are exactly the same. There are three ways that we form blood clots, meaning not three ways, but three risk factors. Okay, so we form blood clots in one of these three conditions. One, inflammation or injury to the endothelial to the endothelium. Endothelium is the innermost lining of a blood vessel, whether it's a capillary, a vein, an artery. The innermost lining is the endothelium. So any injury to the endothelium. So who are these patients that sustain injuries to the endothelium? Trauma patients, surgical patients. All right, these are the endothelial injury risk factors. Second, a clot can also form because of hypercoagulability. Hypercoagulability conditions are those wherein you smoke, you have cancer, you're taking oral contraceptive pills, or you have any other blood disorder. That puts you at hypercoagulability. Final risk factor is venous stasis. Whenever blood forms, whenever blood pools for more than a few seconds in one area of your body, doesn't matter whether that's in your heart. Let's say, for instance, you have atrial flutter or atrial fibrillation, blood pools, right, in the atria. Or you could be bedbound, like a Parkinson's, MS, ALS patient, for instance, okay, or a post-op patient, right? Or let's say you're not sick, you're traveling overseas, 13, 16, 20-hour flight, okay, nothing else to do but sit because you're in economy. So you have venous stasis, right? So that increases your risk of a blood clot. So again, three conditions, three risk factors that put you at risk for forming clots: endothelial injury, hypercoagulability, and venous stasis. So these are the three risks that every patient will be assessed for. So every patient coming through our doors, we assess using these three risk factors. We identify, do they have one or more of them? Based on their risk factor, we score them. The doctor will give them a score, and then the higher the score, then the more intensive our interventions will be to prevent blood clots. So it can range from simply putting stockings on the patient or those sequential compression devices if anticoagulation is not an option. All right. And of course, anticoagulation is routine. So it doesn't stop there. A DVT in an arm, a leg can move, correct? Once it moves, then it becomes an embolus. And then there's three places it can go. So pulmonary embolism, which is our topic for today. And then we have a stroke, which we finished previously, and also either a heart attack, which also we already finished. So all those three conditions are caused by a blood clot. So one tiny molecule possibly killing the patient, right? Imagine the power of that molecule, of that clot. So chart 26-9, here are the risk factors in a summary. Okay. Now I'll go straight to because we're not doing DBTs anymore. We're doing the PE. Okay. But again, I'm starting with DBT because the nature, the pathophysiology is the same. And then here's prevention. So how do we prevent blood clots then? How do we prevent a PE? What are the things you notice in the hospital? So every patient is assessed for two things, right? We assess them for DVT risk. We also assess them for stress ulcer risk. So if they have a high risk for stress ulcer, we put them on PPIs, correct? And we give them either H2 receptor blockers or PPIs. And then there's the DVT risk. So they're either on heparin or the sequential compression devices or stockings, right? So they're all mentioned here. And of course, nothing beats early ambulation. That's the best. Okay, so let's discuss treatment because this is really the same. There will be three categories of a PE. We'll get to that shortly. But the mainstay for DVT and PE is anticoagulation. Let me just emphasize why anticoagulation. Now, there is a clot, correct? There's a clot obstructing a leg or obstructing a pulmonary artery or multiple pulmonary arteries. The goal is to stabilize that clot because what will the body do after a clot is formed? Thrombolysis is going to follow. So the very moment a blood clot is formed, thrombolysis will begin right away. Thrombolysis, though, will last a long time, meaning it doesn't, a clot does not dissolve in a few seconds or a few hours. It will take days to dissolve a clot. So all we can do is put the patient on anticoagulants because anticoagulants will prevent new clots from forming and will also prevent the existing clot from getting bigger. That's all an anticoagulant does because what drug will dissolve a clot? A thrombolytic like alteplase, streptokinase, tenecteplase. So any thrombolytic will dissolve a clot. Now, why didn't we resort to a thrombolytic? Did you appreciate the danger of a thrombolytic when we discussed it during stroke? You did not appreciate it? It's a very dangerous drug. Okay, we don't throw around thrombolytics to just any patient. Okay, there must be a legitimate reason for us to give a thrombolytic and no other option. All right, thrombolytics are very dangerous drugs. Okay, let's put it that way. So we don't treat DVTs with a thrombolytic. It's not worth it because the patient may bleed to death as a result. So what's the treatment again? Anticoagulants. Now, as far as ambulation is concerned, because how did the patient get DVT in the first place?
Why?
One of the reasons was venostasis, right? Meaning, were they ambulating? No. So what activity level will be ordered for this patient who has a DVT?
Early ambulation.
Walking.
Are you also concerned of dislodging the clot?
Oh.
Thought-provoking, isn't it? Okay, so here's the because to settle the controversy, this is what we do. 30 years ago, the activity order for patients with DVT was bed rest. Not anymore, because we discovered, well, we put them on bed rest, it actually promotes the formation of more blood clots. So no. So the routine now, the order is we put the patient on anticoagulants and then its activity is tolerated because the patient does have leg pain when you have a DVT. It hurts. So if they can tolerate activity, walking, we allow them to walk. But there must be anticoagulation already started. Does that make sense? Okay. Now, massaging the leg is a different story. Ambulation is allowed, massaging the extremity is not. Are we clear? Right. Yes.
How soon, before they start walking, how
Yes.
long do they have to be on anticoagulant?
Well, depends on what anticoagulant was used.
2 hours.
Again, depends on what anticoagulant was used. Okay, we'll discuss that shortly when we get to the treatment. So you can appreciate what does this anticoagulant do? What does this one do? All right, and how long does it last? Okay. Here's the answer to your question now. Well, depends. What did we use? So there are different options for anticoagulants. First of all, do you know which drugs are anticoagulants? Name a few. Heparin. What else? Warfarin. What else? What? Oh, enoxaparin. Okay. What else? What else? The 10A inhibitors. Nobody mentioned any of those.
Oh.
Apixaban, edoxaban, rivaroxaban. dabigatran, right? So those are your DOACs, right? 10A, factor 10A inhibitors. Okay. Warfarin is a vitamin K antagonist. Then we had direct thrombin inhibitors, which are heparin, okay, and low molecular weight heparin. Then we have the factor 10A inhibitors I mentioned. So we'll go to 26-2 for those medications. Okay. There's also endovascular management, meaning surgery. We can, if the clot is big enough, we can do endovascular. The problem with this is it may dislodge the clot and become a PE, or cause a stroke or even a heart attack. Okay, so that's the danger of doing the surgical option. We call that thrombectomy, a removal of a blood clot. Now, not all clots, of course, can be surgically removed. They must be big enough. Okay, and of course, if it's too small, I mean, how do you get rid of it? If the patient has contraindications to anticoagulants, the only other option is a filter. A superior vena cava filter will be placed. So this looks like an umbrella without the canvas. Have you seen an umbrella without the cloth? No, just the spokes
No.
of an umbrella. You see that after a storm, like people abandon umbrellas on the street. Do you know what I'm talking about? No, just the umbrella with the sticks. Okay, no cloth. That's what the filter looks like. So they'll implant that in your inferior vena cava. And what that does is it's a filter. So it traps large emboli and making it a target. So what we don't want it to do is clog any arteries. So it'll just stay in the filter. And what will the body do to any clot again? Dissolve it naturally. Okay, so over the next few days, next few weeks, next few months, that clot will be gone. All right. Let's go back to diagnostic first. Okay, diagnostic findings. How do we know you have a clot? Well, if it's a DVT, the non-invasive test will be a D-dimer. D-dimer is a fibrin degradation product, meaning after the body dissolves a fibrin clot, what's left behind is D-dimer. I mean, we discussed this in 241 when you were discussing about DIC, right? Okay, so that's D-dimer. Other tests will be, of course, your bleeding times, because we need to establish your baseline bleeding time before we put you on anticoagulants. And we also want to establish your CBC, because platelets need to be established, as well as your hemoglobin hematocrit. In the case of heparin, then of course we need to see whether or not you're developing HIT. Remember HIT? Complication of heparin. Okay. All right, and in the case of we're doing warfarin, then we draw PT-INR. The diagnostic test to confirm a DVT, of course, is a duplex ultrasound. We need to see and find the clot. Okay, we need evidence that is there really a clot? That's the only confirmatory diagnosis, not any blood test. Okay, we need to see it. And that's the plan. Any questions so far? Okay, let's go now to a PE.
Professor, remember you were saying something was a vitamin K antagonist?
Warfarin.
Right? And
Yeah.
you see how like vitamin K is needed for clotting, right?
Yeah.
So, like, why would you continue eating foods like spinach and stuff like that?
Who's eating spinach and stuff like that?
You don't understand the question I'm trying to.
Who's eating?
The patient.
Why did the patient eat it?
Whatever, right?
Okay.
Okay.
We'll discuss that later. Here, again, we discussed about the activity, right? Which is controversial. Okay, so here, please read here, and that will alleviate your concern. When the patient is on bed rest, the feet and lower legs should be elevated. Of course, that will promote venous return, so preventing further venous stasis. And active and passive leg exercises. All right, so are we okay? So we do encourage leg exercises, including walking. All right. Yeah. As long as, again, what is already on board?
That's fine.
Anticoagulants. All right. Okay, let's discuss the medications now. Table 26-2. Unfractionated heparin. So this can be given either sub-Q or continuous IV infusion. The half-life is 60 to 90 minutes. I repeat, half-life of heparin, IV, okay?
Mhm.
IV is 60 to 90 minutes. What does it do? Prevents extension of a clot, prevents new clots from forming. We mentioned that earlier. And like I said, sub-Q or continuous IV. Okay. If it's IV infusion, then the dosing will be based on the patient's weight, and the dose will be ongoing dose moving forward will be based on the patient's PTT. Okay. So if the PTT is too low, because we want the PTT to be higher, correct? The PTT is too low, what do we do with the dose?
Hold it at night.
Higher, we increase it. If the PTT is too high, we lower the dose. If the PTT is therapeutic,
Keep it.
we keep the dose. Okay. Again, watch for HIT. It is a heparin. All right, low molecular weight heparin. This is subcutaneous injection. Half-life is 12 hours. Same, it's a heparin, so prevents new clots from forming, prevents existing clots from extending. Since the weight, the dose here is also weight-based, so is it necessary to, plus it's 12 hours half-life. We give it once or twice a day. Is it necessary to check PTT while on enoxaparin or dalteparin? Is it necessary? It's based on the patient's weight.
No.
Does your weight change from day to day drastically? No. Our weight changes like weekly, right? Weekly but overall, does your weight really change that much?
Yeah, it's on diuretics.
Huh? Yours does? I haven't seen your uniform seems to be the same fit on you. Hasn't shrunk. Huh? You lost it, huh? What are you doing?
Huh?
What are you doing? We'll talk later. So it doesn't really require PTT monitoring when you're on enoxaparin, okay? But heparin infusion, do we require PTT?
Yes.
Every 6 hours,
Mhm.
right? During the infusion. Next, warfarin. Okay, so question from Jennifer. Vitamin K antagonist warfarin. Now, vitamin K is a vitamin, warfarin is a vitamin K antagonist, meaning it prevents the liver from synthesizing vitamin K. So when I take it today, starting today, my liver will stop synthesizing vitamin K. What is vitamin K? It's needed to form factors 2, factor 7, factor 9, and factor 10. Be clear? So there are 4 vitamin K dependent clotting factors. Now, if you go back to Dr. Farrington's A&P, how a clot is formed, there's a series of activating clotting factors, right? In order to activate thrombin. And then from thrombin, you will form fibrin, correct? So if you stop these clotting factors from being formed, can the cascade proceed? No. No thrombin activation, no fibrin, there's no clot. Are we clear? So that's how warfarin works. By inhibiting vitamin K, because vitamin K is needed to form these 4 clotting factors right here. The problem is when I take it today, it will only affect future vitamin K synthesis. Meaning it will only affect from today, I cannot produce factor 2, factor 7, factor 9, and factor 10. However, Were these clotting factors already in the bloodstream from a few minutes ago or a few seconds ago?
Yeah.
Yes, they're already circulating in the bloodstream. So, will you see the effect of warfarin right away? It will take days. Okay, so we have to wait until all those 4 factors already in the plasma leave the body. Okay, before you can see warfarin's effects. So, can you use warfarin today and then expect anticoagulation?
No.
No, there will be no anticoagulation when I start warfarin. I will see anticoagulation when?
Please.
3, 5, maybe 7 days later. Okay, so do I need some other drug today?
Yeah.
Yes, that will be heparin. Because heparin is a direct thrombin inhibitor. This will give me anticoagulation right now. Once you press start on the pump and heparin starts infusing, I will no longer make clots. My existing clot will no longer get bigger. Are we clear? Okay, so you need a bridge when you're on warfarin. Okay, so warfarin, when you start warfarin, don't expect any anticoagulation. There will be none. So you need another drug. So I'll be on heparin and warfarin until I meet the INR. So and let's say the doctor sets let's say it's a PE, right? So for warfarin, if it's a PE, usually the INR goal is 2 to 3 for a PE. DVT maybe 1.5 to 2. Okay, but for PE, it's 2 to 3. If it's a recurrent PE, it'll be 3 to 4.
What was the
Right.
DVT?
1.5 to 2. Are we clear? So you understand the mechanics? Okay, why people will be on 2? All right. If it's warfarin, right? It's a different story for these guys right here. Factor 10A inhibitors work differently. They only target or prevent the formation of factor 10A. So 10A is not the same as factor 10. Okay, so factor 10 is different. Factor 10A is where the intrinsic and extrinsic pathways meet. So this is a totally different clotting factor. So from factor 10A, once this is formed or activated, this will now activate thrombin. Okay, and then after thrombin, then you have, it will catalyze, millions of molecules of fibrin. Okay, and then you have multiple clots. All right. So these guys are fixed dose. Let's say in rivaroxaban, that's 2.5 to 5 or even 10. Depends on the patient's needs. Okay, risk factor. The doctor decides the dose. So these are factor 10A inhibitors. So therefore, doesn't really require any diet because only warfarin was affecting vitamin K. So that's the only one that has any diet restrictions and requires, blood testing. Heparin also requires PTT. Warfarin requires PT-INR. These things here do not require any diet or any lab monitoring. Okay, so they're very convenient. Sad thing is these things also do not have any antidote. Okay, so unlike warfarin, what's the antidote?
Vitamin K.
And what's the antidote for heparin?
Protein sulfate.
Okay, these things have no known antidotes. Only this one has an antidote. Dabigatran has an antidote,
What is,
but all the others,
what is the,
none whatsoever.
what is the,
Dabigatran. This one has an antidote.
what is what's the
Right here. Idarucizumab. Then finally, thrombolytics. So thrombolytics are reserved only for massive PE. We'll discuss that shortly. Here's your teaching for patients taking anticoagulants, any anticoagulants. So you have to educate, of course, depending on specifically on what anticoagulant they're on. Okay, because it's specific, let's say warfarin, of course, the vitamin K and the PT-INR, heparin, PTT. And again, if it's low molecular weight heparin, there's none, right? No blood monitoring, no diet restrictions. And the rest of these, of course, are either preventing bleeding or recognizing signs of bleeding.
Right.
All right. So read it on your own. Any questions? Okay, let's go now to PE. So we discussed the management for DVT. So you'll see it's very similar here. Now, first of all, a PE is a clot obstructing an artery. Does that sound familiar? What did we call it if this clot obstructed a coronary artery? Because it's a clot, right?
Mhm.
So this clot obstructed one or more branches of the pulmonary arteries. If this clot ended up in a coronary artery, what do we call it? Clot obstructing a coronary artery. What do you call that? A coronary artery. We did this in week 2. What do you call it? A clot in a coronary artery. Anthony, what do we call it? A heart attack, infarction, an MI. If this clot ended up in a cerebral artery or the carotid artery, what do we call it? A stroke or a cerebral infarction. Why is this called pulmonary embolism? Why not call it pulmonary infarction? Why? The answer is, what kind of blood flows through the pulmonary artery, sorry. What kind of blood flows through it? Oxygenated or deoxygenated? This blood does not carry any oxygen. So first of all, are the pulmonary arteries supplying oxygen to the lung tissue?
No.
They are not. They went there to get oxygen. Okay, because that blood does not carry any oxygen. It came from the right side of the heart, correct? So therefore, how does the two lungs therefore get their oxygen? Through the bronchial arteries. So the bronchial arteries is a branch. Once the aorta descends, the descending aorta, one of the branches there is a bronchial artery, which supplies the left and the right lung. So you can say the pulmonary artery, does it really perfuse the lung tissue? They do not. Okay, because they carry no oxygen. However, the bronchial arteries, which branches out of the aorta, those carry oxygen. You understand? So this is not called pulmonary infarction. Okay, this is just pulmonary oxygen embolism. Of course, oxygen is affected because again, this carries oxygen back to the heart, correct? Once it goes to the lungs. So some branches are obstructed. So does all the blood return to the heart carrying oxygen? No. Some of the blood never even get to the lungs, right? If the obstruction is on a major branch of the pulmonary artery. So we already discussed the risk factors, so same risk factors as DVT. We'll skip that. Manifestations, it's not really specific to the PE. The manifestations are the following. Are they really exclusively found in a PE? This signs and symptoms look like a heart failure patient, a heart attack patient, a asthma patient, a COPD patient, right? These are the manifestations, exactly the same, yeah? So when they come into the ER, do we only test for one thing? We will test for everything. So we will draw troponin, we will draw BNP, we will draw D-dimer, draw everything because we don't know what this is. So if the labs come back normal, no troponin rise, no BNP rise, but positive D-dimer. So what do? Maybe a PE, okay?
When the lab come back and it's no.
So it's not a heart attack. So BNP is normal, not heart failure, yeah? All right, so the gold standard for how did we diagnose a DVT again?
We check, we assess for venous stasis.
No. Diagnose it. How do we diagnose a DVT?
Ultrasound something.
We looked for it, right? Okay, so we needed to see the DVT. What about here? How do we know it's really a PE? D dimer's high, but the gold standard is CT scan. CT angiography to be specific. Angiography meaning you're using a dye. Okay. So again, D dimer's positive, then we send the patient for pulmonary arteriogram or a VQ scan. The pulmonary arteriogram is, of course, the angiography. We use a dye to inject. Now, of course, what is a contraindication to this test?
Diabetes. Metformin.
AKI. Yeah. Yeah. Poor kidney function because it's harmful, right? A dye can destroy kidneys. Yeah. Intrarenal AKI. Okay. And then, of course, we will hold the metformin. Right? After receiving this, then we will tell the patient if you're on with metformin, okay, it will be held for how long? 48 hours, 2 days. If the patient has any elevated BUN creatinine, meaning AKI, right? So can we do the CT angiography? No. So what will we do instead?
VQ scan.
Okay, VQ scan. VQ scan is a nuclear medicine test. So instead of using a dye, we will give the patient radioactive gas. So we will have them inhale the radioactive gas. And then take pictures. So we'll take the patient to nuclear medicine, they'll inhale the gas, and then whichever part of the lung doesn't show up the gas, meaning, did not enter the alveoli, then there's the obstruction, right? Let's go to treatment now. So we confirm it's a PE. There's 3 categories of a PE. There's low risk, meaning very mild. Second is the most common, which is submassive, which is moderate. And then severe is massive PE. Massive PE is also called hemodynamically unstable PE. So these are large size clots or also multiple clots. So the patient here, imagine, so if the pulmonary arteries, many branches are blocked, totally blocked, what happens to blood flow to the lungs? So when the right ventricle pumps blood, can it reach the lungs? And then if so very little blood gets to the lungs, how much blood returns to the left side? Very little. What happens to cardiac output? Is this shock? What type of shock is this? Obstructive shock. Okay, so this can kill the patient. So the patient will go into cardiac arrest. So what do you think will the treatment be if it's a massive PE? First, we'll deal with the cardiac arrest. So what do we do? Okay, CPR, okay, full ACLS. And then meanwhile, there's a clot. So what do we do? Alteplase. Okay, alteplase will be given.
That's the submassive, right?
Massive PE. Okay, massive PE. Hemodynamically unstable PE. So again, life-threatening emergency. So hypotension, meaning obstructive shock, severe tachycardia, confusion, then again, cardiac arrest. So here's the management I already mentioned. So please read. Okay, the patient will go into cardiac arrest, cardiogenic shock, and obstructive shock at the same time. So treatment is what again? Okay, CPR. After CPR, chest compressions, and then we do alteplase to dissolve the clot. Okay. Or we can do surgical embolectomy if indicated. And after this, if the patient's risk is really high, then they'll advise remember the filter? Okay, so after a massive PE, the patient is advised to get an IBC filter. Okay, they may not survive the next one. Okay. Now the stable PE. So this is now the submassive PE, stable PE. Stable because the blood pressure is fine. Blood pressure is normal. Oxygen saturation though is low. Patient has desaturation. So the treatment here is simply anticoagulation. What drug? The doctor will decide based on the patient's symptoms. So if let's say the patient has AFib, right? AFib, a flutter, depends again. What's causing the AFib or a flutter? If it's a valve disorder, the only recommended anticoagulant is warfarin, nothing else. If it's caused by a valve problem, are we clear? Non-valvular clotting, non-valvular AFib, therefore the PE was caused by AFib but not because of a valve problem, then we can use the other anticoagulants, dabigatran, apixaban, rivaroxaban. All right, so those are the options. Any questions? Okay, so here's what the filter looks like, okay, in case you wonder. They may have this umbrella or it may be just sticks. Okay, there's different types. The green filter is just sticks. I don't know what this brand is. Not sure. All right, so anticoagulant is the mainstay for submassive or stable PE. And then for low risk PE, those patients don't even get admitted. They'll just be placed on maybe, depending on the risk factor that we identified, they'll be put on maybe low molecular weight heparin injections once or twice a day at home, right? We teach the patient or a family member how to administer the medications. Or sometimes they place on apixaban, you know, the direct oral anticoagulants
Yeah,
for,
that's
let's say, 6 months, okay? And then stop after that. It's a low risk PE.
Oh.
Okay, so we already discussed thrombolytic therapy. I'm not repeating that. The dose, of course, is different. It's not the same dose as stroke, because this is a PE.
Well, Professor, submassive is long-term anticoagulant and the low risk is low molecular for 6 months, right?
Again, it could be low molecular weight, but it could also be any of the non-warfarin direct oral anticoagulants. Duration is always decided by the doctor, depending on the patient's risk factor, because they score them. The score is a certain number, then that will determine how long. And the rest of these are symptomatic management. So for pain, patient may receive either NSAIDs or opioids. Give them oxygen, of course. The moment they enter the ER, that's the first thing we slapped on the patient is oxygen. Goal is 95% or better. Relieve anxiety. This is the patient, one of the manifestations was, yeah, sense of impending doom. So we do need to address that. And complications, of course, is shock, especially if it's unstable or hemodynamically unstable or massive PE. And the goal, of course, upon discharge is to prevent new clots from forming. So we identify the patient's risk factors extensively and do extensive education that this is serious, okay? They survived this one, great, congratulations, but you may die the next time. All right? And here's your summary. Chart 2611, teaching for patients when you're discharging someone after a PE. Okay, two very short topics. Let's go ahead and knock these out of the way. So that was chapter 26. We'll go back to the gas exchange chapter, unit 4, chapter 19. Go to respiratory failure. Okay, these two are very short.